you, Dr. Edwards, and it's a great pleasure to be here. Thanks all of you for coming out today to hear a little bit about our recent health reform law and some of the implications of that law. I want to start by saying that as the media discussion around this law suggests, this is a landmark achievement in the health system in this country. And it's not necessarily a landmark achievement for the reasons that everyone thinks it is if you just follow it in the media. It seems like a lot of the debate that goes on around the Affordable Care Act focuses on its most controversial issues, focuses on a lot of the challenges to the law, including the pending litigation in front of the Supreme Court. But unlike a lot of the critics of the law, which suggest that this is a complete government takeover of the healthcare system, or a foray into socialism, or even some of the disappointed proponents of health reform who say that this is a completely inadequate, overly market-focused approach to dealing with some of the health problems in this country. I think it does fall certainly in between those two poles of opinion, and I think it's actually likely to have a substantially greater effect on public health than a lot of the commentary seems to suggest. And I started thinking about this issue about a year ago after reading an article that one of my close colleagues had published, really criticizing the legislation from a public health perspective, essentially saying that the way the law was structured was they missed an incredible opportunity to really advance public health through this legislation, and making a number of really good points, which for the most part I agreed with. But I felt like there was another way to look at the legislation that would take its provisions into account and think about what the likely public health implications would be, and then also to look at it from the perspective of the right to health. Some of my work focuses on international human rights law, and it's always frustrating to think about international human rights, especially the right to health, when you're working in the U.S., because the United States has been extremely reluctant to recognize certainly international human rights treaties that recognize affirmative rights to health and education, social welfare, etc. And yet, I began to, as I thought more about the legislation, come to the conclusion that in a lot of ways this legislation is kind of a subterranean advance in realizing the right to health in the United States. But despite the complete opposition legislatively and judicially against recognizing the right legally, many of the preconditions that are recognized in international documents looking at the right to health for having a society that upholds the right to health were actually being achieved or could be achieved through the implementation of this act. And so that's what I want to talk about today. I'm going to focus primarily on some of the history of the act, the decision to not pursue more public health oriented approaches, and the decision to not pursue a more formalized acceptance of the right to health in U.S. law, but then talk about how, despite that, I still think that there will be significant public health advances and significant advances for realizing the right to health as a byproduct of this legislation. I'm not going to talk very much about the litigation going on in front of the Supreme Court, but if people have questions about that later on, if we have time, I'll definitely address that as well. Okay, so historically, we've seen many efforts in this country to try to pass comprehensive, or at least a systematic national system to govern health. And going back almost 100 years, the first attempts at the federal level were made by Theodore Roosevelt back in the early part of the 20th century. FDR wanted to have universal health coverage included within the New Deal, but was unsuccessful. Social Security and other major federal programs were enacted during his presidency, but was unable to get a universal health coverage system through. And then more recently, we've seen a lot of efforts, primarily Lyndon Johnson's Great Society programs, including Medicare and Medicaid, and then subsequent efforts by Nixon, Carter, and Clinton to really try to push substantial national health reform with very little success. Obviously, the Medicare and Medicaid programs had been a great success, but the consistent theme across all of these efforts in the past was that every time there was a proposal for a federal reorganization or a greater federal role in the healthcare system, there was always substantial political opposition. And the political opposition came from a number of sources. It usually came from people politically predisposed to want a smaller role for federal government. And you know, I love this picture, which is actually an old LP sleeve. Ronald Reagan speaks out about, or speaks out against socialized medicine, excuse me. And so you have back in the 1960s when Medicare and Medicaid were being debated in Congress, this was one of Reagan's first major forays into politics, was this sort of national campaign where he was the face of the campaign against socialized medicine, which was to try to stop the Medicare and Medicaid programs from gaining passage. But this debate, as you all know from having seen it in the last couple of years, at least from a political perspective, played out exactly the same way when President Obama attempted to enact health reform legislation at the beginning of his term. Now, another thing that's sort of interesting historically is how our perceptions of and how the actual content of these policies has shifted over time, along with the political winds. Obviously, I mentioned that Nixon had a health reform proposal. Nixon's health reform proposal was actually more liberal, or further to the left, politically speaking, than the recent legislation was. Late in his life, Teddy Kennedy said that his greatest regret was not taking Nixon up on the offer to make a deal for a national health insurance system back in the 70s, when that was on the table, and he wanted to hold out for a better deal. Interestingly enough, a lot of the provisions that are in the current health reform legislation are provisions that were originally proposed by Republicans in the early 90s in opposition to the Clinton plan. And so the individual mandate that everyone is very concerned about actually came from proposals from the Heritage Foundation, which is a right-leaning policy think tank. And so we've seen the contours of what the different sides in the debate find acceptable shift over time. Despite that, there still has been a fairly constant struggle to find common ground and to actually enact something that was comprehensive enough to greatly reinvent the system. And even major programs like Medicare and Medicaid, and here's Lyndon Johnson signing that legislation with Harry Truman sitting on the side there, were piecemeal approaches, covering certain segments of the population, and only involving certain segments of the population in a national system. And we see at the beginning of President Obama's administration, one of the reasons that his administration pursued this national health reform legislation again was that there was a perception that both with his political mandate in the election and with just the needs of the country, that there would be sufficient political support this time for a national kind of plan. And so I just wanted to spend a minute or two sort of pointing out a couple of the salient public health facts about where the US stands in terms of relevant health indicators. And this is something that's always sort of amazing to me. When you look at our expenditures, the United States spends far more than any other country per capita on health costs. Almost double the next highest spending country, which is Canada. And you can see on this slide here, $7,290. This is from a couple of years ago. And 17.3% of GDP. Compared with Canada, who's in second place on the expenditures, which is only $4,400 per person, and the UK, which is $3,800. Despite that, you see that the US has less good, less effective measures when it comes to some important population health measures. So we're 34th in the world in terms of our rate of maternal mortality. So that means our maternal mortality is higher than 33 other countries that all spend much less than us on their healthcare systems. Childhood mortality rank, we're 40th in the world. Less effective not only than our nearest competitors in expenditures, but less effective than lots of other countries. And so it's a little bit hard to see, but you can see on the one side, this is our rank in infant mortality in 1960. So there are only a couple of countries that had better, or I should say lower rates of infant mortality in 1960. We've dropped all the way down in 2004. Now our rates have improved since 1960, but everyone else's rates have improved more, and yet we're spending increasingly more and more on our health costs. And there are a couple of reasons for this. One reason is that we do spend a lot of our money on high technology healthcare as opposed to prevention, which is one of the themes that comes out in the legislation. But we also have significant health disparities in this country. There are, if you're wealthy and have good health insurance in this country, you get pretty good care, and in fact, you may get some of the best care in the world depending on where you're actually receiving it. That being said, there are significant portions of the country, significant components of the population, significant areas where, because of lack of insurance or lack of access, people are not getting the kinds of access to health services. They're not getting the kinds of information they need to protect their own health. And so there's a much greater range of disparity across the population in terms of health outcomes, which affects our overall rates significantly. To kind of flesh this out a little bit more, you can see here, these are the sources of insurance coverage. You'll see all the way on the right there, 15.8% of the population in 2007 in the US was uninsured. Comes out to about 40 to 50 million people in that range, depending on which study you look at. And you can see, for the most part, the other people who are insured primarily get their insurance coverage from either employer-sponsored plans. That's the big bar on the edge of the graph on the left side, about 60% from employer-sponsored, and then about 25% more combined from Medicare and Medicaid. So most people are getting their insurance from those sources, but we still have nearly 16% of people who have no insurance coverage at all, and so when they get sick, they can't effectively pay for care. They may get care in an emergency room. They certainly aren't likely to be able to pay for preventive services and other kinds of important health services. So we also see over time that this is getting worse. And in fact, this data only goes up to 2006. You can see the amount of the rate of uninsured is slowly rising. Certainly it's worse now because of the recession of the last couple of years. People losing their jobs, people having less access to that employer-sponsored coverage that was demonstrated in the earlier slide. And so when the legislation was proposed, the fundamental justification was we need to raise our rates of health insurance. We need to make sure that there aren't 40 to 50 million people uninsured in this country. And the projections back when the bills were being scored by various government agencies, you can see that that top line was the projection of the number of people uninsured in millions if there was no change in the law. So gradually increasing 51, 52, 53, 54 million people uninsured. The projection, the dark blue line in the middle there, was the projection for the law that actually passed. That it would actually greatly reduce the number of uninsured people. Not eliminate, reduce it down to about 23 million, and perhaps even lower. So it's not going to achieve universal coverage, but it will greatly increase the number of people who do have access to insurance. Okay, and so I'm going to skip ahead a little bit and talk a little bit about the passage of the law and the content of the law itself. One of the things that was really significant about the strategy for how the law was structured and passed, or what I found particularly interesting in thinking about these issues in the context of public health and the right to health, is that when you look at the arguments that were being made around the legislation in Congress, in public, by the parties either arguing for the law or in opposition to the law, there was surprisingly little, relatively speaking, discussion of the public health effects of the legislation. There was quite a lot of attention paid to the more practical, direct effects of the legislation. We want to increase access to insurance. There was less discussion of what that increase would actually mean for public health purposes, and the sort of public health goal, the sort of overriding idea that we need to improve overall health in our society, kind of took a backseat to arguments about, oh, we just need to have a more orderly system, we need to let people keep their insurance. It was very much focused on these sort of nuts and bolts practical effects rather than any kind of big picture narrative, which I found to be surprising. And to some extent, this was, I think, just a strategic consideration. And to some extent, I think it was meant to minimize some of the political opposition. One of the things that was very different about this round of legislation compared with the previous ones was that the longtime opponents of the law, like the insurance companies and the AMA, the American Medical Association, were actually supporting the legislation. They were brought into the fold by designing the law in a way that would be more palatable to them. And so this is one of the big criticisms of the law, of course, which is that it's too oriented towards the private sector. Instead of having the government take a direct role in providing either health services directly or at least health insurance directly, the legislation routes it through the private insurance system and essentially gives them a windfall of additional insured, covered people who will pay premiums and increase their bottom line. Now, the other thing that I found interesting in the rhetoric surrounding the law, and the absence of this in the law itself, was any significant references to health as being some kind of fundamental right to this country. And you know, when President Obama was making his case in front of Congress, they called the joint session of Congress in the fall of 2009, and he laid out his 3 reasons why this law was absolutely imperative to pass. His reasons were increasing the stability and security for those with insurance, providing insurance for those who don't have it, and restricting costs in the health system. Not exactly the most lofty goals, but you know, very sort of practical goals. And the only time in that entire speech that he even mentioned this sort of larger issue of population health or any kind of right to health was when he quoted a letter from Ted Kennedy, who had recently passed away, urging him to go forward with the legislation and extolling the fundamental principles of social justice and the character of our country underlying the health reform proposals. And so aside from this fleeting reference, there's no real push to tie this major health reform initiative to any kind of fundamental right to health or recognition of the broad importance of health, which, again, I think is interesting, probably politically strategic, but I think also a missed opportunity, because there are a lot of reasons that having that more lofty rhetoric and trying to link health to this broader fundamental social need and social right is morally compelling and actually something that I think would be beneficial. So I want to talk a little bit about the details of the Act, and first to talk about why I think it will actually have a more substantial public health effect. And when I say public health, I'm talking about the population level health effects of the Act than a lot of people have seemed to suggest. And then I'm also going to talk about how, in many ways, these same provisions in the Act are paving the way, or at least creating the opportunity for a greater realization of the underlying determinants for a right to health in the United States. Any questions so far? That was a lot of background, but is everyone still with me here? Okay, good. Let me talk about, I'm going to try to very briefly summarize the law, which is hard to do. You can see the picture there, that giant stack of paper. Every time there's a big piece of legislation, you know, one of the favorite media tricks of opponents of the legislation is to bring out the bill and put it on the table, and it's this high. And it's look at this ridiculously long piece of legislation. It's far too complicated. Well, the Affordable Care Act was an extremely long piece of legislation, incredibly complicated. And despite that, I think you can think of it fairly simply as falling into 3 major categories of provisions. One category deals with, which I'll talk about first, deals with quality improvement, prevention, and public health. And actually, these provisions are probably the most insignificant in terms of the scope of the Act, but I'm going to talk about them first. Then I'll talk about the health insurance reform provisions, and third, the cost containment provisions. And so when you look at the quality improvement, prevention, and public health aspects of the law, there are a couple of key provisions that really are designed directly to affect public health, that are designed to create advances at the population level for health outcomes. And so, for example, you have the National Prevention Strategy, which is essentially an attempt to create a plan that would be implemented nationwide to create healthier communities, improve social determinants of health, including the ability to pay for health services and education, reduce harmful behaviors linked with preventable diseases, etc. And the initial draft of this plan, which was produced in furtherance of this legislation, is a sort of a core, fundamental, direct public health approach. There's the Prevention and Public Health Fund, which is actually a pool of money designed to go towards prevention and public health initiatives. Initially, there was $500 million budgeted for this fund, although in the first year, Congress actually only gave half of that amount to public health and gave the other half to efforts to try to increase the healthcare workforce, which was actually criticized by a lot of people in the public health community, but still probably served a very important goal in the overall health system infrastructure. There are provisions in the legislation that create demonstration projects, which are essentially projects where there's sort of limited funding to test things out to see if they work, and if they do, then perhaps to extend them on a broader base. So looking at comparative effectiveness research, so looking at hospitals and other healthcare institutions and trying to see which approaches are most effective, both from health effectiveness and cost effectiveness, to try to see best practices and improve on those practices. Accountable care organizations. This is probably one of the most significant features of the new law, incentivizing health systems to streamline their operations and have coordinated care within their institutions in order to have efficiencies, but also in order to have greater health benefits, greater health outcomes by coordinating this care. And there's actually
DMC one of the test organizations. Just heard on the radio.
Yeah. DMC is trying to form one of these accountable care organizations. And there are some models out there already that are in existence that this idea is based off of. But most health centers and institutions have not gone down this road. And there was actually a really interesting article yesterday in the New York Times that was talking about the accountable care organizations as being sort of the subterfuge to undermine the entire health insurance industry, which I thought was pretty interesting. And I don't know if that will come to pass, but the overall idea here is actually twofold. It's both an idea to improve health outcomes by coordination and greater interconnectedness between healthcare providers within the system, but it's also, as I'll talk about again in a minute, it's an idea to reduce the cost of healthcare by having efficiencies in the system, both of which could have benefits for public health. And both could have benefits in addition because they would allow for greater opportunities for prevention instead of waiting until someone got sick before receiving care. And then finally, there's explicit requirements for coverage of preventive care and services. And this is, this happens in several ways. One of the provisions in the law requires Medicare and Medicaid to cover preventive care services and implementing greater access to those services by people who use those payers as their insurers. But it also requires that employers and other health insurers who are providing health insurance coverage include certain preventive services in the things that they automatically cover. And so therefore expands the opportunity to receive preventive care. Okay, and so now another point that I wanted to highlight is that the overall structure of the law things I just mentioned are a very minor portion of the law. The majority of the law focuses on health insurance reform. I'm going to talk about that in a second. But this tracks very closely with our current status quo and how we spend our healthcare money. Most of the money that we spend is spent on individual healthcare procedures. You can see by this chart, hospital care and physician and clinical services are over 50% of the money spent. What's that?
Is that the brown on the
Yeah,
right?
so right here, this is hospital care, 31%, physician clinical services, 21%. So over 50% of the money we spend is on individual healthcare services, presumably through insurance companies or other insurance mechanisms paying for these, for the most part. And then you have other professional services, 10%, nursing home and home health care, about 9%, drugs, 10%, other products, 3%, 7% on program administration, and then you have investment, I think it's 5 or 6% there, 3% on public health activities. So the law does perhaps a little bit to change that in that if these preventive services and other initiatives actually gain some traction, they could perhaps expand that amount spent on public health activities, although it certainly doesn't directly fund a lot of the public health activities that are done at the federal and state level, and so it's unlikely to increase that substantially. That being said, I do think that there's some great opportunities for expanding public health under those programs if they're actually funded, and that's a big if, because the way the legislation is written, there actually are only a couple of things that are already funded. A lot of these programs are subject to future future congressional apportionment. So in other words, if future Congresses decide not to fund these programs, they just won't happen. They're authorized by the law, but the chances of this happening, I think are they're certainly not good at this point, considering some of the budget fights that have gone on in Congress in the last couple of years. So that's sort of a little more pessimistic read on what's likely to happen. Okay, I want to talk about category number 2 as well, which is the most substantial part of the law and deals with health insurance reforms. The health insurance reforms in the law have gotten a lot of attention. You're probably familiar with some of these if you've been following it. These three are kind of the core of the really significant regulatory changes here. So we've got limits on pre-existing conditions and limits on exclusions and expenditure caps. So in the past, insurance companies could decide that because you had a long-standing health issue that they didn't want to cover you, and this was completely legal to do. This has now changed. So with the or at least it's gradually being implemented over the next couple of years. As of 2014, when the full law is in effect, presuming it's not overturned or repealed prior to that, which certainly could happen, the law will prevent insurance companies, health insurance companies, from denying coverage based on pre-existing conditions. So it doesn't matter what your pre-existing condition is, they will have to accept you into their health plan, and they cannot charge you an exorbitant price that would effectively price you out just because of that pre-existing condition. They have to pool across the entire pool of their customers to cover anyone who applies for their coverage. And it also eliminates rescission of insurance, so taking your insurance away once you get a condition, which is also something that insurers would often do, except for cases of fraud. So if you've lied on your application about something, they can still rescind your coverage, but otherwise they can't. They've also eliminated lifetime caps and annual caps. So a lot of insurance plans had a limit of how much they would pay per year, or how much they would pay over the course of your life, and those are also no longer permitted. And so this is great. This is great from the consumer perspective in terms of people who are purchasing health insurance, because it really opens up access. And so this is something that has rightly been hailed as one of the greatest achievements of this legislation. The issue that comes up with this, though, is that if you just have this provision, that you limit all these, you limit the ability to exclude people based on pre-existing conditions, you limit these expenditure caps and rescissions, you could face a problem with, it's sort of a moral hazard type problem, where people will just wait until they get sick and then they'll buy insurance, and it'll undermine your insurance pool, right? Because no one will feel the need to buy it until they actually get sick, and you won't have that broad base of insurance premiums from healthy people subsidizing those who need the payouts from the company. And so the law implements a couple of other components. One of them is the individual and employer mandates. The individual mandate has gotten the most attention. You're required to, as of 2014, have health insurance. If you fail to have health insurance, you'll have to pay a penalty. Having health insurance doesn't mean you have to buy it out of your pocket. You could have it from your employer, you could have it from Medicare or Medicaid, you could have it from some other kind of source. But if you don't have it from one of those sources, you have to purchase it. And if you don't, you're subjected to penalties. This was done to get everyone to buy into the system, and therefore prevent the sort of concern that you just have people waiting until they got sick to purchase health insurance. It's also something that the insurance companies are extremely excited about, of course, right? Because everyone has to buy insurance now. It should greatly increase their number of customers and number of people paying premiums. It also leaves another problem, though, which is that if you require everyone to buy insurance, there are going to be a lot of people who just can't afford to do that for a variety of reasons. And so there also are provisions in the law that subsidize people who have lower income to help them pay for this system. And so effectively what you have is the federal government subsidizing insurance premiums that will go to private insurers, or in some cases expanding Medicaid, which is another part of the law, to cover more people. But either way, you're going to have the federal government paying a lot more money to cover healthcare costs. And yet, when they do the budgeting analysis of this law, it comes out to actually save money, and that's because actually giving people access to care and having people have access to insurance so that they can go and actually get that care, in the long run will lower healthcare costs across the whole system. Yes?
But does it shift the cost from one group to another group?
Not necessarily. There will be some shift in the cost because, I mean, to some extent, a lot of this cost is borne by healthcare institutions who serve people who come into the emergency room who don't have insurance, or you know, others who can't pay their health bills because they don't have insurance. If the government is subsidizing insurance for many people in that category, or maybe expanding Medicaid to include them and cover them under Medicaid, and so the government essentially becomes the payer either directly or indirectly, the federal government will be covering more of that cost than had been the case before, in some cases. On the other hand, you know, even people who you know, have some insurance or may be covered under federal programs for insurance like Medicare and Medicaid would presumably benefit from this strengthening of the system. And you know, the idea is that by having this comprehensive universal coverage system, you increase access, and at the population level you lower rates. How that shakes out in terms of the distribution of who pays, I don't think they've completely sorted out yet. But you know, I think you're right that it would fall more on the government and therefore more on sort of the taxpayer base than it would have previously. And so that is a consideration. Yes.
I think there are two changes that make this mandate even more important. One is the decline in the number of unionized employees in this country keeps going down. And unionized employees, I guess as a group, get insurance provided by their employer more than non-unionized people do. And secondly, our tax system subsidizes, encourages the consumption of health coverage through the special preferences for not taxing insurance premiums that your employer provides. And there's been a lot of talk about ending that. And so it seems to me that the Affordable Care Act, at best, is just going to tread water if it is successful, if these other changes continue to happen.
Well, I think that, especially in the kind of post-recession economic dynamics that are going on right now, and some of these longer term things that you're talking about as well. It's not certain how effective these, in terms of overall coverage. I think it will be effective in the sense that you'll have far more people overall being covered, who they're covered by, and the scope of what they're covered for is going to be different. I think because people who were employed in a union job with a good health insurance plan are not necessarily going to have the same benefits in Medicaid as they would, or in one of these plans purchased through a health insurance exchange. So I think that, and that will, in some sense, it will lower costs, but it will also lower access to certain health services. One of the arguments that's often raised is that a lot of these health services are unnecessary. And, certainly there's waste in the system, but it's not clear whether there's a good sense of how to effectively implement that kind of analysis and determine what services are extraneous. One of the things, and I'll mention this now, one of the cost containment initiatives in the Act are to place an excise tax on plans that give what they call excess benefits. So in other words, to deter people from offering health insurance plans that are what are perceived to be overly generous and therefore driving up health insurance costs. And I don't think that's a positive thing for public health, but is probably a positive thing for cost of the system. Yeah.
Is that like the supplemental plans that people buy from the AARP, or is that just like a special plan? What do you mean? Do you mean like special people for special income groups, or what?
Well, the way that it's described in the law is they direct federal agencies to come up with a definition of a list of some kinds of services that are deemed to be excess services, things that are not that are not required to adequately protect health, and therefore will increase overall costs. They have to actually define excess services. So it's not necessarily a specific plan, and a supplemental plan wouldn't necessarily be considered excess services. But the sort of example that's often trotted out for this are some of the union health benefit contracts that are very comprehensive and can cover almost any kind of health service. Lots of well checkups and things like that. And again, I think this is fairly controversial because it seems to be deterring use of health services and sort of trying to categorize them as to these are necessary and these are excess. And I don't know how that's going to play out in terms of what it will end up, what market effects it will have to have this excise tax. A lot of institutions might decide, or a lot of insurers and employers might decide to continue to offer these services anyway, continue to insure them despite the tax, because they just think that it's an important benefit for their employees. But I suspect it will have an effect of deterring those kinds of benefits from being offered. Okay, let me mention a few more things. I know we're getting a little bit short on time, and I don't want to completely run out. Health insurance exchanges are a core part of this law as well. Every state is required to create a health insurance exchange to essentially make it easier for consumers to buy health insurance and to kind of aggregate all the information in one place. You can purchase it through the exchange. The federal government will be setting up exchanges for states that wish the government to administer this for them, or states can do it on their own. It's up to the states. Now, I didn't include the chart, but I was doing some research the other day looking at this, and it's interesting, because of the political opposition to this legislation, a lot of states are refusing to, or at least greatly dragging their feet on creating these exchanges in the hope that it'll get overturned at the Supreme Court or it'll be repealed after the presidential election. And so a lot of these states will end up with the federal system being their default system because they haven't gotten it together in time. They have to have it together by 2014. Michigan is one of the states that has not yet moved forward. I know that the governor is willing to move forward, but the legislature is not as willing at this point. There are a couple of states that have flatly refused to move forward on health exchanges, while there are others that have already made a lot of progress in putting theirs together. But obviously how these are structured will greatly affect how the system operates as well. And then one or two other really important things here. Essential benefits. The law requires all insurance plans, sort of the counterpoint to what we were talking about before. While there's a discouragement of excess benefits, there also is going to be a list of essential benefits that all plans have to cover. And to some extent, this is actually a little bit more oriented towards preventive services than it has been in the past, which I think is a potential boon to public health because, again, a lot of these preventive services were not covered under existing health plans. Now, the criticism of this approach is that it eliminates some amount of consumer choice in terms of people selecting what they want in their plan. And if all plans have to have certain essential benefits, then it makes all plans required to cover certain things, and therefore certain low-cost plans would be off the table. And there are both states and companies that have been trying to get the government to grant waivers for some of these essential benefits plans, to offer lower cost plans that don't have all the benefits for workers who wish to have those. And finally, other expansions to access. There are a couple of other things that are going to have a great deal of effect. One of them is that the law, over a period of about 7 or 8 years, closes what they call the donut hole in the Medicare Part D prescription drug plan. So Medicare Part D covers prescription drugs for people on Medicare. Right now, when you get up to a couple $1,000s worth of expenditures, the program stops paying until you get a couple $1,000s higher in expenditures. And so there's a couple $1,000s per year in that donut hole window that people are required to pay out of pocket. This would gradually close that and cover drugs at a certain amount all the way through. It also, the legislation also it expands Medicaid. I mentioned this before. So Medicaid eligibility, so Medicaid's the program that covers low-income people. It's a health insurance program that states administer with support from the federal government. States are required to expand eligibility in their Medicaid programs. This, by the way, is the other issue that's in front of the Supreme Court besides the individual mandate, about whether it's appropriate for the federal government to expand Medicaid in this way. Okay, so I want to stop there for a minute. Actually, no, I don't want to stop there for a minute. I want to do one more slide, which is cost containment, and then I'll stop, and we can talk a little bit about some of the implications. I mentioned the excise tax on excess benefits, and I've mentioned the accountable care organizations, which are the effort to incentivize organizations to create a more comprehensive coordinated care system. Both of these, well, the accountable care organizations, I think will have great benefits for public health because of the coordination of care aspects of that approach. It remains to be seen, though, whether it's going to actually contain costs in the way that they think it will. There's also a move to reduce payments from the federal health insurance programs, Medicare and Medicaid, to health providers. So the amount of money that a physician or a nurse would get reimbursed for treating patients in those programs, who are insured by those programs, would decrease. Now, again, it's unclear whether this is actually going to come to pass because this has been proposed for many years, and then Congress always overrides it. They say, well, we're not going to do it this year, we're not going to do it next year, in part because of the strength of those interests in advocating for that higher level of compensation. And so, whether that's politically feasible to actually reduce those payments will, I think, dictate in large part whether the cost of the overall legislation ends up increasing or decreasing healthcare costs, because that's a big chunk of the costs. Remember the graph, the payments to hospitals and payments to providers was over 50% of what we spend on healthcare in this country. And finally, I'll mention the Medicare Independent Payment Advisory Board. This is another somewhat controversial proposal. It creates a board within Medicare to essentially determine which procedures should be covered, which procedures are effective, which procedures are worth the cost. This is not what people were concerned about when they were talking about death panels, but this seems to be closer to the concern that people have about somebody, an insurance bureaucrat deciding whether your procedure is covered or not. The idea behind this, though, is that there would be a streamlining of care, that services that were unnecessary or inappropriately expensive would be excluded from Medicare, and that other services would be included, and that presumably this would not affect the overall availability of effective health care, although it remains to be seen whether they can actually do that effectively. Yes?
Is that, for lack of a better term, is that essentially turning this all into like a big HMO sort of thing?
That's one of the concerns, is that that you end up having kind of preemptive rationing by saying, well, certain services we're just not going to cover. But at least presumably the way this is structured is that you're going to have a bunch of medical professionals, not necessarily people who are looking at the bottom line, saying these things are effective, these procedures are worth paying for, these other procedures, they're a lot more expensive and they give the same result, or they give an equivalent result. So they're looking at the cost, but they're not looking at the cost with the goal of reducing the overall cost. They're looking at it in terms of effectiveness. And so at least that's the defense that people give. And this hasn't been implemented yet. And so we haven't actually seen how this would operate. By the way, the sort of HMO critique also comes in with the accountable care organizations. That you're going to have these organizations that are coordinating care. Will this lead to the denial of certain services because of the interest of the if you're paying the organization for outcomes, or if you're paying the organization a certain amount, capitation was the approach that HMOs used, where you sort of had a lump sum payment or a certain maximum payment for the patient services, and however they used that money to provide the services, that was all they were going to get. It wasn't fee for service. It remains to be seen whether the accountable care organization model will have some of the problems that HMOs and that capitation had, or whether it will be more effective. What some people have suggested is that the advantage of this new model, as opposed to HMOs, is that with the HMO model, it was the insurance executives and people who were primarily, Chair, I keep almost tipping out of it. The insurance companies were dictating based upon cost concerns more than care concerns, and at least theoretically, these are going to be the people who are treating the patients. Although, practically speaking, there's still going to be management in these organizations who are going to care about the bottom line. And so I'm not completely convinced that the outcome is going to be different. So I actually want to stop here because I think, and I'm going to kind of defer on some of the right to health analysis because I don't think we have time for it right now. But I'm happy to talk a little more about that if people are interested. And so I guess a brief conclusion is that despite the complexity of this legislation, despite the fact that it's primarily focused on changes to the health insurance system, I still think there's great potential for significant public health improvements, primarily linked to the increase in access. I don't know if it will be successful in containing costs, but I think regardless of whether it does that or not, there is a great potential benefit for population-level health outcomes stemming from these changes. And sort of the related point, which I haven't gotten into too much detail about, but I think stems from that same, or I guess I reached the same conclusion with regard to the right to health, that even though this legislation doesn't recognize a right to health, it doesn't use the rhetoric of rights to health, a lot of the things that are necessary to achieve good health, and the things that you would seek in trying to establish a right to health, these underlying determinants of access to care, of increased quality, of an efficient system that actually is sustainable. All these things move along that track, and so actually move closer to that realization of a right to health across the population in the US. And so let me stop there. Have about 5 minutes before 1:30, but people can stay longer. I don't have anywhere to be. I'm happy to stick around, and I'm happy to talk about more, either about some of the human rights issues or about the litigation that's in front of the Supreme Court. Questions? Yes?
Yeah, I just received Paul Starr's new book through interlibrary loan yesterday, and I was kind of looking at it before bed last night, but just in the introduction, he's, I don't know whether you've had a chance to look at it.
I haven't seen the new book, no.
Okay.
No. But I've read a lot of his work in the past.
Yeah, but I mean, he's in favor of that ACA, but he thinks that that parts of it were not well fashioned. And I was just wondering if you knew what his objections are.
I don't know specifically what his objections are, but I can tell you my own objections. I mean,
Okay.
I think that I generally agree with that statement. You know, I think it's a great advance. It's much better than what was in place before, and it's certainly better than not having done anything. I think that it is too focused on the private insurance system. You know, it's a very inefficient way to achieve the goal of actually any of the goals. So if you want to improve public health and quality in the system, if you want to reduce the costs of the healthcare system, if you want to provide greater access to insurance, there are much more direct ways that you can do all three of them than the way the system is structured. You know, it's in order to maintain the status quo of the private insurance system, it was fashioned in a way that causes a lot of indirect additional expenditures, you know, a lot of externalities that don't need to be in there. And so you could achieve all these goals more effectively in a much more direct way. And that would, you know, be either having a single payer system or having a system that permitted the government to take a more active role. And so a lot of you will remember the debate about the public option, right? You know, should the government be a player in the insurance market directly in these health insurance exchanges? And that was taken off the table during the negotiations on the legislation. You know, either of those, either the public option or a single payer, would clearly be, I think, more effective from a health outcomes perspective and also more efficient. And so yes, I mean, you know, there are certainly alternatives that would be better. That being said, I'll take this over nothing any day, because I do think it will have substantially beneficial effects to population health, and you know, it'll have I think it'll have a lot of other beneficial effects as well. You know, in terms of how the system will change to adapt to these new requirements. Other questions?
Yeah, yes, as a person who has had to deal with this system over the last couple of years, I went through a long story I won't go into, but my question is, you mentioned about the public option being off the table. Why did it get off the table? Who's opposing this? I mean, I'm thinking if it's from a profit perspective, the money is going to come in like crazy if all these companies get their money. So who's opposing this? And okay, to be fair, who's more in support of it? So where are these two opposing camps coming from, and why is there such vitriol?
Well, I think the vitriol is, I mean, I don't know if I can explain it in any kind of direct, obvious way, but I think, you know, certainly these debates were about a lot more than just the design of our healthcare system and our health insurance system. For a lot of, you know, a lot of this is kind of politics being mapped onto this large policy debate, right? Because you know, you know, certainly a lot of the opponents of this legislation were, I guess, conveniently opponents of it, because, you know, many of them supported similar proposals in earlier years, but because their political opponent was, you know, was offering it, you know, this was a way to, you know, deny a victory to a political opponent. So I think that political, you know, sort of the broader political fight is certainly a big part of some of the opposition, and some of the I think, you know, certainly the insurance industry was opposed to the public option because it would create an additional competitor for them, and you know, the argument was that if you have the government becoming a major player in the insurance market and competing directly with private insurance companies, the government has inherent advantages because of their size, because of their ability to have a greater pool of resources, perhaps you know, other built-in advantages, and that this would be an unfair playing field. It would either put these insurers out of business and sort of be a Trojan horse for a single-payer system that everyone would eventually gravitate towards the government option, and therefore it would kind of become a de facto single-payer system. Or, you know, the other concern was that it would just, you know, there's sort of just an additional bottom line concern. We're not going to be able, you know, it's going to force, even if we can compete, it's going to force us to drop our prices down. It's going to force us to, you know, change the way we offer our services. And so they were effective in getting enough support in Congress to have that removed. And so yeah, there are a lot of factors there. I think those are some of them, and I'm sure there are others.
One other question, I'm sorry, but your question was, your whole talk was excellent. It gave me a lot of insight. My question is, a person who both has both Medicare and Medicaid, I find I'm still getting billed for things, and I find that I'm caught between huge bureaucracies where I have to go to different places to get information from people, and it's like pulling teeth. And then I go and I find out something else, and somebody says, well, you didn't talk to this person over here. Well, wait a minute. I didn't even know they existed. And then I found this intermediary of bureaucracies are in between, and nobody's talking to each other. So what is going on? Are these like separate bureaucracies, like in tangent? Nobody's talking to each other, and it seems like all the burden is on the patient suddenly.
Yeah, well, I think your experience is a very common one in dealing with the existing health insurance bureaucracies. I mean, Medicare and Medicaid. I mean, to some extent, that their systems have improved over the years because a lot of it is electronically accessible, and payments are done more easily. But in terms of navigating the systems, it's extremely complicated. You're absolutely right. One of the things the legislation tries to do is to further streamline access to medical records, or for bill payment purposes. The accountable care organizations are meant to streamline some of the aspects of the actual healthcare experience, and trying to get organizations to coordinate internally. Although that doesn't necessarily mean that your interactions with your health insurer are going to get easier. One of the big criticisms of this approach, again from the perspective that it's too dependent on the private insurance system, is that it's one of the similar critiques that was raised with regard to Medicare Part D. So Medicare Part D is the prescription drug section of Medicare, and it's administered by private insurers, and there are hundreds, and probably thousands actually, of insurers, and so when you turn 65, as a close family member of mine recently did, and had to decide which plan to get, it was this amazingly complicated decision that was essentially a lot of guesswork, and very difficult for not only the average person to navigate, but even a very well-informed person to navigate. And I think that when you hear these calls for greater consumer choice, a lot of consumers really don't want that choice. They want more help and they want to deal with less of those details. And so I think that's a very legitimate concern, and it's one that certainly hasn't been resolved in any substantial way. But yeah, thank you for your questions and comments. Any other questions or thoughts from anyone?
Do you have more questions?
Okay. Well, thanks everybody.